Good morning and welcome to the Mailman School of Public Health's Grand Rounds on the future of public health. We're thrilled you're here. After witnessing the devastating toll of this pandemic over the last 8 months, where we saw, to paraphrase the New England Journal of Medicine, a public health crisis turn into a fast-moving tragedy, it seems only fitting that this year, the Mailman School of Public Health is devoting this series, this Grand Round series, to understanding our existing US public health system and how it is leading on preventing people from getting sick in COVID and how it needs to lead for the future, what we need to do to strengthen and even redesign it for the 21st century so that we're better prepared and protected against the next epidemic and to protect and promote health broadly. Last month, we kicked off this Grand Round series with a very significant conversation with two leaders for the public's health. Dr. Axiris Barbeau, former Commissioner of Health for both New York City and Baltimore, and Wes Moore, the CEO of Robin Hood, focused on creating a public health system for health equity. For those of you who are unable to attend that, I encourage you to visit our YouTube channel where you can find the recording of that talk along with other Grand Rounds lectures. As COVID has exposed the many weaknesses of our existing public health and medical care systems, it has also demonstrated for everyone to see how structural racism impacts health. I suspect many of us would argue that the US public health system should play, must play an important role, a leading role in solving the impacts of racism on health and well-being. As you all know, our public health system includes the Centers for Disease Control and Prevention, the 50 state health departments, the 3,000 local health departments across the US, and health departments for tribal lands and territories. Interrogating what we need this amazing system to deliver in the future requires reimagining the status quo and deciding what the future requires. And that leads me to our esteemed guest today, who has been leading the charge on change for some time now. So it's my real honor to introduce somebody who probably needs no introduction here, Dr. Mary Bassett, for today's lecture on public health and racism. With more than 30 years of experience in public health, Dr. Mary Travis Bassett has dedicated her career to advancing health equity and addressing head-on racism's role in health disparities. As Commissioner of Health for New York City, she worked to ensure that every New York City neighborhood supported the health of its residents, with the goal of closing gaps in population health across the city. During that period, we were delighted as a school and honored to have Dr. Bassett as a member of the school's Board of Advisors. Prior to that role in leading in New York City, she was, among many other things, the program director for the African Health Initiative and the Child Wellbeing Program at the Doris Duke Charitable Foundation. She is currently the director of the Francois Xavier Bagnot Center for Health and Human Rights at Harvard University. Our event today is broken into thirds. Dr. Bassett will start the conversation with a short presentation. I'm then delighted to welcome Dr. Wafa El-Sadr, University Professor and Director of ICAP at Columbia, and of course the Amfar Mathilde Krim Professor of Epidemiology at the Mailman School of Public Health, who will join Dr. Bassett for a conversation about structural racism's impact on health. We'll then conclude our event with an opportunity for all of you in the audience to ask questions to Dr. Bassett. Please submit your questions using the Q&A box at the bottom of your Zoom screen. And now I'm thrilled to turn to Dr. Bassett. Mary, thank you for joining us.
Thank you, Dean Freed, and it's really a pleasure to join with all of you. I'm just going to talk. I am not going to show you some slides today, and talking about this session. And I really want to commend the Mailman School of Public Health for dedicating this series of conversations to the issue of structural racism. We thought it might be interesting for you to hear from someone who led a large local public health agency about what the commitment to put racial justice and equity at the center of its agenda, what it meant for us in terms of the internal life of the New York City Health Department, at least what my intentions were in pursuing that work. So I thought I would talk a little bit about that. And this is something that I haven't written about. It's something that, of course, reflects my tenure, which ended in September of 2018. And there have been two health commissioners since, one currently serving, Dave Chotsky, both of whom have been committed to the notion of health equity, but may interpret it very differently than I did. But just to frame this conversation, let's start out by acknowledging that what has unfolded in the United States was really entirely predictable. And that there has been such a disproportionate impact in the United States was predictable. And that impact has also fallen disproportionately on communities of color was also predictable. So in many ways, the COVID-19 pandemic has displayed the ways in which our societal structures have created vulnerability to a microbe. Many people have commented, and I've been reading a book which I'll hold up, but you'll see it as a mirror image. It's called Epidemics in Society by Frank Snowden, a historian of the Renaissance at Yale. And he points out, as have many people, that epidemics really say more about societies than they do about biology. And the susceptibility of our society to this was predictable. The US has been engaged in a 40-year project of dismantling its social safety nets as compared to other wealthy nations. We are unique in our inability to provide worker benefits like paid sick leave, unique in our tying health access to healthcare to our employment system. And we are unique in our embrace of over decades, indeed centuries, of the concept of white supremacy. So these are all things that made us particularly vulnerable and help explain why, with under 5% of the global population, we comprise over 20% of the cases. And many of these things existed way in advance. Problems existed way in advance of the current administration, which of course has completely sidelined its public health agency, the Center for Disease Control, and has muzzled its scientific leaders, and in general has led a chaotic and fragmented response, squandering public trust in public health. So those are all, sort of the context in which I'm going to speak, but I'm not going to talk about the way in which structural racism has been revealed in the COVID pandemic, except to note the disproportionate impact. Papers that actually will be coming out later this month, but is in a preliminary form published as a white paper, looking at age-specific mortality, show extreme increased risk, particularly among working age adults, in the Black, Latino, and Indigenous populations. So as Dean Freed has said, the idea of social justice and racial equity have been central to my working life. And I put at the center of what I intended to do as health commissioner when I took on that role in 2014 as an appointee of the de Blasio administration. And I said in a notice to the staff that this was going to frame everything that we did. And that meant externally in the work that taxpayers pay their taxes to support public health, in the external work of the health department to examine how racial equity would alter our work, and also in the internal life of the agency, which is usually less visible to the public and less visible to the academy. So in terms of thinking about how we would frame our external work, we obviously, the New York City Health Department is a premier health agency by any standard, and certainly a leading urban health department in the nation and probably in the world. It's got enormous expertise that it was an honor to lead it. But we wanted to build on the strong policy strategies that had been developed, particularly during the Bloomberg administration, and the use of the health code to tackle the modern scourges. We also have, have the whole area, in addition to policy, of programmatic approaches. But what I felt had been missing was a better engagement with community. So in terms of the external function of the health department, the idea was that we needed a stool with three legs, and we needed strong policies that were that enabled people to have access to healthier choices. We needed to direct our programming to the communities that bore the highest burden of disease. And that was through what were initially called district public health offices and then relabeled as neighborhood health action centers. And additionally, to embrace the idea that health is not only a technical project, that there are very few examples that are in alignment with, the fluoride in the water. Where you get, you keep drinking water and you get your fluoride, and we don't need to alter behavior. That most public health interventions require the understanding, participation, and collaboration of the communities that we hope to serve. And that was really a focus of strengthening that, principally in the context of the neighborhood offices that have been located in the Bronx, Brooklyn, and in East and Central Harlem. So that was really the external frame. And internally, the charge was to the entire agency to take up the issue of racial equity. And the argument was that this was not only a challenge to the district offices or to the newly established Center for Health Equity, it belonged to every single division in the department, including the administrative divisions. How does the health department spend its money? Where is it being directed? What about its hiring practices? What about its contracting practices? What about even IT was challenged to take up this work? And I think that was really an important addition to say that we shouldn't pigeonhole the responsibility to ensure that New York City tackled better the enormous inequities, which I expect that most of the listeners don't need me to read off a litany of the way in which the national experience of racial inequities is replicated in New York City. Despite its history as a liberal, forward-thinking city, it is one of the most segregated cities in the United States. And that, of course, was the platform on which Bill de Blasio was elected, that it should be one city, not the tale of two cities, that served all of its people. And so that was also a challenge. And I have to say that often I'm asked, for the roadmap. How do you, tell us exactly what each entities should be doing. And what I learned as commissioner was if you give people a challenge, they will rise to it. And it was actually the emergency preparedness people who came up with, who brought the whole legacy of redlining to the department, because they did an analysis of how well staffed the emergency response would be across the different boroughs if people had to walk to a place where emergency measures were being dispensed. And they found that the South Bronx, a formerly, a historically redlined area, would have been among the worst served. It was the public health engineers who, unbeknownst to me as commissioner, started a swimming program that focused on communities where we were seeing excess drowning, swimming pool deaths. The public health engineers both look after swimming pool safety and investigate swimming pool deaths. But I want to take the remaining time that I have to talk about the internal effort that began as what was called internal reform. That was my language. When I joined the New York City Health Department, the senior leadership team had no Black or Latinos in it. And that reflected a real failure of the New York City Health Department over many, many years to reflect the city that it served. So using the standard that the mayor had outlined, that people in leadership in the city's agencies should be well-trained, reflect the values of the administration and the composition of the city, I was proud to lead the senior team to a majority non-white team, meaning Black, Latino, Asian, for the first time in its history. And I would say to you that it's important to have a leadership body that, reflects the diversity that we hope to attain. And of course, in a city agency, one is able to do that. And it was a very exciting period. When I became commissioner, I was the first Democrat elected as mayor in over 20 years, in 20 years. So, the leadership was diverse in a way that it hadn't been before. I used to joke often when I talked about it that we even added some men, which the leadership of the health department, like much of public health, is one of the fields where women have been able to take leadership. So the health department began this internal reform, which was really an educational process, making sure that people understood the importance of social justice and racial equity. And it was eventually rebranded as Race to Justice. By the time I left the health department, the training unit that had been established to oversee this activity, not within the administrative side, but in the Center for Health Equity, had succeeded in training about a fifth of the employees. And this was one-day training, which was a substantial commitment. The leadership of the agency had undergone more training than that, often with contracted training group, which I'd be happy to talk about what groups came in. And additionally to this training, we developed an online package and successfully negotiated to have this training added to the tasks and standards of the agency, which means that everybody has to do it as part of their routine work. And that, I hope, ensured some sustainability across administrations for this work. In addition, as commissioner, I started something called the Commissioner's Brown Bag series. And that was a monthly lecture during lunch. That's why it was called the Brown Bag series. And it was open to the entire agency. So often lectures were, somewhat elitist. There was the senior staff who were invited. This was open to the entire agency. And there were times when we had 300 people in the room to hear these lectures. That people came, and members of the faculty at Mailman were among them, who really for the opportunity to speak to public health practitioners. And we had, many people from many disciplines, and the general theme was the pursuit of racial equity and also the history of the United States. That's something that I think in many ways has been, even as well educated as we all are, we have not learned enough in terms of understanding our own history. So that, in addition, and also there was a real effort made to expand, to really reinvent our ability to reach out and change the recruitment strategies and hiring strategies, the contracting strategies. So I'm at time. This is what happens when you speak without many notes. And I'll wrap up then by saying that in general, we saw it as both an internal process focused on changing the life of the New York City Health Department and an external process focused on changing its work practices.
Well, thank you. Thank you very much, Mary. And it's really great to have you back with us and to see how you're continuing to build on your really lifetime commitment to public health and global health and commitment to equity and combating racism and white supremacy. So thank you. I want to start the conversation, and I want to give everybody a chance to, while we're starting this conversation, to also please, if you can put your questions in the Q&A box, that'd be great as we move on with this section of the webinar. So, with the COVID crisis, I think, which has highlighted, again, the disparities that you mentioned very clearly, many of us, including the Dean, yourself, and many others have been raising the issue of the decades of disinvestment in public health and calling for a reinvestment in public health. Yeah. I want you to, what do you think about when you think of investment in public health? Because it's not just, we don't just need the funding, but we need to invest in changing what public health does. So I just want you to comment on how you see, if we are to get truly an investment in public health, how can we make that investment achieve what you wanted to achieve, what we all wanted to achieve?
Well, that's a very big question. And of course, it speaks to the fact that not only does the US spend less proportionally on public health than any other wealthy nation, that proportion has been declining at both state and especially at local level. And I'm talking about government funds and the support to government public health agencies. That is, partly to blame for the real difficulties that public health agencies had responding with agility to the COVID-19 crisis, the archaic and wobbly IT systems. So there really needs to be a larger budget share for public health. Additionally, I think that I would argue that that some of the functions of public health need to be reimagined and I didn't mention it, but we all know that the COVID crisis also intersected with the police killing of George Floyd and highlighted the the fact that the US actually has a more lethal record of police encounters than other wealthy nations, and that a disproportionate share of people who lose their lives as a result of police encounters are African American and Latino and Indigenous, particularly African Americans. So, you know, we often have become the handmaidens to clinical medicine, to the police department in their encounters with mental illness, and we should be in the lead. Public health should be in the lead of these, and because it's in the population that people become healthy. So I really think that we need to reimagine public health as having not only the staffing and training and infrastructure that it needs, but having a broader role in society. And that it should, I would love to see, you know, clinical medicine hitching its wagon to public health as opposed to public health hitching its wagon to clinical medicine. Or the police, like, for example, with, and I hope questions are coming in, but when New York City took the courageous act of adding a lot more money to its budget to tackle substance use disorders, and particularly the overdose epidemic, it added $60 million a year. And of that, 12 million came to the health department, and the remainder went to the police department. So this is a common breakdown of 80%, 20%. And, you know, I had a fraternal relationship with the then police commissioner, but they were investigating overdoses as homicides. And that is not a public health approach to the overdose epidemic.
I mean, it's interesting that, you know, when we think about it, that certainly public health owns or feels that it owns the whole area of social determinants of health.
Yeah. Well, the then deputy mayor used to say, Mary thinks everything should be public health. And that, I guess that's kind of true. Yes. But I think that, what I learned to talk about was not health in all policies, but equity in all policies. Yeah. But I do think that there should be more, like, for example, contact tracing, which is so important at the present moment. It should also be a gateway into the, to the social supports that people should have access to help get them through this pandemic. Not only to find out who's infected and who's not, but to ensure that people have resources for, to eat, to be housed, and so on.
I mean, as you know, you're talking to a public health community of faculty and staff and students. And, I was thinking, like many of us pride ourselves in studying a lot of these issues and so on. And what do you think the role is of schools of public health in really helping catalyze change in terms of the health of communities and wherever they're situated, whether it be the local communities or the global communities?
Well, I obviously am a big fan of seeing public health take some responsibility for population health. I mean, academic public health. And that has happened historically. For example, historically, one of the first population surveys of the health in Harlem was done by Sociomedical Sciences at Columbia. And that should lead to actions. I think that we have the responsibility, as some famous person said, not only to describe the world, but to change it. And I think that responsibility also lies with the academy. There's a whole fleet of energetic and activated people called students who I think would be happy to work not only on data collection, but on interventions. And I know that does happen. It should happen more. Many health departments have had relationships with academic institutions. And I think that those are very strong. a pathway to linking research and practice. And additionally, many schools of public health are located in poor communities because they grew up alongside clinical institutions, which historically teaching hospitals are, take care of poor people. And, I would love to see a commitment to improving the health of those populations. But that takes resources. And in my current position, I'm learning about the structure of the financing of academic public health. And unfortunately, it has many challenges.
And it's possible then, as we're thinking of maybe this new investments in public health, that it becomes critical for public health leaders and practitioners and others to engage in defining where that funding should go and
Yes.
should be done by that funding if we are to get to our collective goals.
I think in the global arena, we see a better. I mean, your own work, for example, is very much applied in the global sphere, and is directly improving the health of people living with HIV. So I think somehow this division between research and practice, between clinical medicine and public health, in the developing world is less onerous and has been better overcome. Do you think so?
I do agree with you. I think for maybe it is because of in many ways because of people think of health as public health because the issues are so prevailing. The health issues are so prominent and very broad. Yeah. And also there hasn't really been an established, unfortunately, an established public health discipline as much as we want it to be established in any country. So it's necessity that people who are involved in health have had to really be involved in public health. And
yes, I mean, the Ministry of Health does both clinical services and public health.
Yeah, so there's less.
Yeah. No, I mean, that was really my background because I lived in Zimbabwe for many years. And that's what I was thinking when the district public health offices were launched in New York City.
One other thought is that we've talked about sort of the need to transform health departments, to transform what they do and who they are, and as institutions. And I'm wondering about the other challenge, which is that things are very much siloed. And when you think about the social determinants of health, it means really connections to education, connections to policing, like you mentioned, and connections to environmental issues and the economic situation in a city or a community. And can you share with us maybe your experience in New York City of what worked and what didn't work in trying to break through some of these silos in order to achieve what you really wanted to achieve?
Well, of course, what really would have been exciting is to have a mayor say, in these communities where we have low educational attainment, health outcomes that are below the city's average, where, I want all of you to work together and join up the effort of government to and coordinate it, because at the ground level, these fragmented vertical things continue to play out. And we have to believe that if we were able to work more cooperatively, that there would be a larger impact. It's really, really hard to do. Obviously, there are reasons for efficiency that silos emerge. I suppose one of the examples in New York City of what's now a pretty long-standing collaboration between the health department and the Department of Education is the school health program. It's formally a joint program where the staff, the leadership of the school health program has space both in the Department of Education, and at least he did. and seeks to work jointly with both the educational structure and the health structure, making the case that healthy children come to school better prepared to learn, and that this is an investment that is that supports the mission of the Department of Education. The efforts to work collaboratively with other structures include homeless services, the Department of Sanitation. You can imagine that all of these offer opportunities for improving health. At the same time, the chain of command is all vertical, and the only joint formal chain of command that I can recall now is the school health program. That's the biggest program at the health department, which probably means it's the biggest school health program in the country. And it employs thousands of nurses and so on.
And before we go to the questions from the audience, I had really the pleasure of reading an article you just got published actually yesterday or the day before yesterday.
Oh, in Nature.
Yeah.
Yes.
And it just reminded me of probably one of the most memorable articles I've read this year was in June by Nikole Hannah-Jones.
Yes.
In the New York Times, entitled "What is Owed," in which she talked about the issue of reparation for Blacks for slavery. And it was interesting to me reading your piece is how you connected economic health to health, and how reparations could advance economic health and thus lead to health. And I'm just wondering if you briefly can share with our audience.
Sure. Now this is one of you're referring to a piece that I wrote with Sandra Galea, who's well known to many of you, and is now the dean at BU, on proposing that we should look at reparations as a strategy for reducing Black-white health disparities. Mm-hmm. And I wrote something else in Nature, which calls on researchers to not sit on the sidelines in this period. But in any case, reparations has long been viewed really as just a complete non-starter. In fact, in many ways, I viewed it that way for a long time. And I have come to view it as something that we should be talking about. The work of course, the first person to raise this was Ta-Nehisi Coates in an article in The Atlantic. Nikole Hannah-Jones, who remains, just an incredible beacon within journalism, as far as I'm concerned, for her 1619 project, but she also has continued to be the brunt of attacks for her work on that project. She also has written about it. And there's a book called From Here to Equality that's written by Sandy Darity and Kirsten Mullins that also raises up the issue of reparations. And the basic idea here is that we in public health can make the case that this not only is a moral or economic issue, that it's an issue that involves health, that there really is an abundance of literature that ties income to health. And although it's thinner, data that supplies, that supports wealth and health. And in fact, it may be that wealth is a more important determinant of health. This means your total assets, not just your income. And of course, there's a much larger racial disparity in wealth than there is in health. So I believe that we should look at this. The gaps are so large, it's 10-to-1, that they are absolutely rooted in the historical fact, and this is a fact, that the enslaved population was released from enslavement and told, go on, good luck, you're free, with no compensation for what was centuries of unpaid labor. that propelled this nation into the, top echelons of wealthy nations. That didn't end there. If you look at this book, From Here to Equality, it's just a painful story. The fact that Reconstruction, which offered an opportunity for another pathway for the United States, was turned back, and a reign of terror began in the States that led to thousands of extrajudicial killings, et cetera, to redlining, a really powerful example of structural racism. Onwards, we have seen that there have been innumerable barriers to Black advancement, particularly the population of US descent. So yes, that's why we said we should start looking at this. I felt like I was brave when I talked about racism in the pages of the New England Journal. It's, I guess, 5 years ago. And now it's time to start thinking about reparations.
Thank you. And I recommend this and your other piece to all of our audience as well. We'll move on now to some of the questions from the audience.
Sure.
Lots of questions, Mary, so I'll pick and choose some. One of the questions is, how important do you believe it is to collaborate and engage with communities of color? And do you see that the efforts that have been attempted have succeeded or not succeeded? What have we learned from all the attempts of the past? What have you learned from?
Well, let me just talk personally. A prime example at the New York City Health Department was the collaboration of the Maternal Infant Reproductive Health Group with the reproductive justice activists. This was the first time that they had been invited inside the health department and asked to share their views. And it was a real learning experience for me. I'm trained as a physician. I have to say that we are rather top down in our, that's encouraged. We assess, give advice that we think people should follow. So there was a good data that the use of IUDs was really a better strategy for young women in terms of pregnancy prevention. Then we need IUDs everywhere, was sort of my take. Young women, have to have much enhanced access to IUDs, and there's good evidence that when it does happen, teen pregnancy rates decline, and most of those are unplanned, unintended, and unwanted. So it was pointed out that this was really not the right stance to take, and so the whole conversation around how the department would promote access to contraception and would frame the fact that people should have children or not according to their desires, and that both should be supported by society, was a real learning experience for me. And the health department embraced sexual and reproductive justice as its strategy, released a whole set of guidelines on birth justice and what women can expect when planning to welcome a child into their family. So that was a real learning experience and also for the staff, which had long been doing what it considered good work. I considered good work, but never involved the voices of advocates from the community.
Yeah, this is a lesson we all have learned the hard way, but it's one that's durable. Once you never unlearn it. The next question I have is prefaced by somebody saying that's an unfair question, but nonetheless a question. Considering the situation we're in now, the really catastrophic situation in regards to the U.S. response to COVID and so on, the struggles we're having in the city and elsewhere, what would you, thinking back now, what would you have done differently in your role at the Department of Health then? What would you have prioritized, with 2020 hindsight?
Oh gosh.
That may
Well, I don't think it should be it's not an open question that the response was delayed everywhere, including New York City. The question is why? Part of it is a technical answer. I don't know, and I guess someday we'll know why the CDC's testing products were messed up. And so that in New York City, there was clearly community transmission that was unidentified. And testing would have made that possible. I don't know why internationally, the World Health Organization, which we're no longer part of, had identified tests in Germany. I don't know why the US has to do things itself and didn't bring in its own, useful and validated tests while it figured out its own tests. So that's part of it, a technical issue of the limitations of testing. I also have asked myself, because this, speaking personally also, why was it that we had such difficulty getting our heads around exponential transmission? And why did we think that a highly contagious virus in China might just stay there as opposed to spreading everywhere as it has? And part of it, I think, has to do with, this continued idea of people being different. I remember thinking to myself, I don't know how people are living in China. Maybe they're living 15 people to a room there. And that's why Wuhan is seeing this outbreak. And of course, we have the exact same situations here. We have people living 15 to a room here, and the inability to recognize our society as it really is. So, to answer the unfair question more directly, New York should have decided to shut down sooner. That probably would have saved lives. Yeah. The economic impact is one that we can afford as a nation, the way it was done in Europe, where people were not just given unemployment, but their employers were given the money to continue to pay people their salaries, seems a wiser strategy to me. Mm-hmm. And the fact that there's been an unwillingness to open the coffers is short-sighted. Mm-hmm. This is a costly outbreak due to a novel virus, but this is a very wealthy country.
And maybe it is, maybe it is also a focus more on response rather than focus on preparedness. I think sort of the importance of always thinking being the preparedness, the response, and then the recovery, rather than often it's focused on the response at the moment.
Well, the shutdown was supposed to buy us time to prepare our response, right?
We weren't prepared at the beginning. I meant like a priori prepared.
Oh, I see. Yeah, you mean having contact tracing available on that kind of scale before?
I guess I'm thinking the preparedness of the public health system, having a stronger surveillance system.
Oh, yes. Yeah. But in this case, the surveillance was there.
Yeah. Maybe another question that's I'd like to ask, and then see if the dean has a question as well. And it's important for institutions to also acknowledge their history and their role in mistakes and injustices and so on that they have perpetrated in their past. And one of the questions is given that public health participation and endorsement of racial projects like eugenics, and also in things like the Tuskegee experiment, for example.
Sure.
How should public health deal with this, with its history, and acknowledge it, and help take the lessons learned to inform the future?
Right. And of course, I don't know much about Columbia, but certainly Harvard, and many leading universities had benefited from the enslavement of Africans. So the founding grant for the Harvard Law School came from a Massachusetts family that owned large plantations in Antigua. So this, this history needs to be acknowledged. That's very specific. Additionally, there are more subtle ways in which racism has been structured in by the uncritical acceptance of the idea that race is a biological variable, and which public health has a lot to answer for, in my opinion. So part of this is, is series like this, where we reinterrogate and acknowledge that we have much to answer for. It was only in 2008 that the American Medical Association apologized for its long-standing exclusion of Black physicians, for example. Yep. So, this is not ancient history. Yeah. It's still very much with us. And yeah.
Thanks. And maybe I'll ask our Dean, Dean Freed, do you have a question or a comment for Mary?
Well, Dr. Bassett, thank you as always for your leadership. And I guess maybe I'll end with a comment for the future, another question for the future for you. You invested deeply in really defining the role of a local health department in resolving structural racism and advancing health equity. What have you, can you out of that provide a prescription for what public health systems should be responsible to accomplish programmatically in communities going forward to really advance health for communities with high rates of health disparities because of racism?
Well, that was the concept of the neighborhood offices, and the idea that, for a long time there was a tension between centralization and decentralization. As you know, that on the corner of 168th Street and Broadway is a building that was a joint project between the New York City Health Department and Columbia. As a district office. There were once some 30 odd of these around the city. But here, the idea is that there are some communities which, because of the legacy of bad policies like redlining, are disadvantaged and have legacies of deprivation. And so that the most expensive programming, which usually means programming that takes people. Policy is not free, but it's much less expensive. So home visiting, working with communities on controlling rodents. These all take human beings, and they should be directed to the communities where the need is greatest. And that was the basic targeting idea of the neighborhood offices. That makes sense to me. And I hope that it continues, but it hasn't always been the strategy. For some reason, I'm wobbling on my screen. Am I wobbling for all of you?
I'm wobbling too.
Okay. Well, so, I think that, so that's the, policy interventions are really important. I really hope that when I know that the priority has to be COVID-19 now. We're in the midst of a tragic crisis, but we still have chronic diseases, and And I would love to see progress made on doing something about sugary beverages. It may seem trivial to many people now, but we still have a huge problem with obesity, which has turned out to be a risk factor for COVID adverse outcomes, and with the epidemic of diabetes. So I want to reiterate that the policy role is very important, and but at the same time, we have to build our alliances with communities, target our highest cost programs to those who need them most. That's the lesson that I learned.
Thank you.
Thank you. And maybe before we end, and I should have called you Dr. Bassett, but we know each other for so many years.
Yes.
Dear
you
colleague.
knew me when I was at healthnet.zw. And you met when I still lived in Zimbabwe.
Yes, of course. And maybe the last question before I hand it back to the dean to end this, to give her closing remarks, is for our students. What do you think their role should be, and how should they do it in encouraging all of us, whether we be faculty or staff or leaders in public health? How can they push us to move forward with this racial equality and health equity agenda?
Well, I would just urge them to embrace advocacy as well as high quality research, and there's I hope an agreement that the human cost of the racial hierarchy in the United States is too high, and that it must end. That was what took millions of people to the streets over the summer. And it represented a sort of an outpouring that I haven't seen in 50 years. So I think we owe a great deal to the young people who took to the streets to express their outrage. And I want to tell them, although we're all taught not to be angry, especially women, I think, are taught not to project it, that they should keep that outrage, and because it really matters, and they should, be sure to get their flu shot and be sure to vote.
Well, thank you very much, and, Mary, and I'll hand it back to Dean Freed.
So thank you to everybody for joining us today for this very important conversation. Thank you, Dr. Bassett. Thank you, Dr. El-Sadr. Thank you for each of your leadership as well as your insightful comments today. For the audience, I want to remind you that this Grand Round series on the future of public health, focused on what we need in a 21st century public health system, will continue in November, when we hear from New York State Commissioner of Health Howard Zucker and Dr. Sherry Ling at the Center for Medicare in Baltimore, talking about how we do a better job of protecting vulnerable populations in this pandemic. So I look forward to seeing you there, and thank you all so much for the shared work we're engaged in.
Thanks, everyone. Thanks, Wafa. Thanks, Linda. It was a pleasure. Bye-bye.